Good afternoon. It is afternoon, right? Good afternoon, colleagues. We are ready to start this session E3 on integrated HIV service delivery with non-health responses. We have two speakers. We would like to just do a final check if we have our third speaker, Mr. Privillage Charashika. Are you around? Okay, so in the interest of time, we will start the session. If Mr. Privilege walks in, please, I'll let him to kindly take a seat. We will start with the colleagues that are here. My name is Kesadu Kole. I work with UNFP. I'm based in Botswana, and I'd be moderating this session. As mentioned, the session is on integrated HIV service delivery services with non-health responses. And we have two speakers currently, Mr. James Mwanza from Zambia and Mr. Shola Adeyemi. I have a different name. Just a sec. In the meantime, would ask the colleagues in the booth to kindly load the presentation from Mr. James Mwanza, who will be our speaker. Each speaker will have 10 minutes. And we will then have a moment for interaction with the audience. Just a moment whilst the colleagues in the booth are loading the presentation. Okay, just a small technical glitch. The booth, if we could kindly confirm that you have the presentation from Mr. Anthony Kinwa. Just give me a thumbs up. Sharp. Okay, thank you. So we welcome you, Anthony. Apologies about that mishap. I think there's a inconsistency on that the information leaflet. So we'll have Anthony Kinwa, who will present on assessing population level for HIV programs among female sex workers and men who have sex with men in Nairobi. Now we will call upon James to give the first presentation. You'll have 10 minutes, James, and then we will interact and then invite Anthony.
Good afternoon. Today, all of us seated here, we understand to say service delivery at health post level, they almost look impossible if you integrate with specialized health services. Most of the time, what we see is it is difficult for us to take health services to the lowest level possible. And this is always left to specialized health centers because we know to say this is where it's supposed to happen. But in a village or in a global village where we've experienced a gap in funding for these services, we need to make sure that services are integrated at a very lower level to make sure that we cut a cost that is associated to access these services. We are looking at a project, we're looking at something that came through. We understand to say Ministry of Health in Zambia has a number of levels of health service delivery. The first level we have is actually at a community, which is the health post level. And this level is the one that is very difficult for us to make sure that they have experienced or specialized services. But we looked at it to say it is possible for us to take services to this level, because once we do that, it means that we are going to address a lot of problems. The project I worked for, we did a feasibility to look at how possible it is for us to make sure that we integrate in this primary healthcare health post services that can fit those that are coming from specialized health services. Next, please. Therefore, we realized to say, because we are supporting Ministry of Health as a project, we made sure to say these services are cutting the distances that people go through for them to go and access services. Because Ministry of Health has got a goal to make sure that all our health services are within a radius where people are able to access. Secondly, we made sure that we cut the travel costs for the people that are accessing the services. Apart from that, we decongested the services. So our integration was mainly to make sure that we address the barriers that are associated with access to these services. And therefore, we took the services that are only expected to be found at specialized health services to the health post. What did we do? Next slide. We had to hire specialized healthcare workers. The specialized healthcare workers are the ones that helped us making sure that we work using the hub and spoke model. And this is a model that was able to expand the services, because the people who were specialized, they were sitting at the hub, however, going to all the outreach posts, which we call the spokes, and they are the outreach sites, which are health posts. They started offering technical support and mentorship. Apart from offering the technical support and mentorship, they also made sure that they transferred their own skills to the people that are found at these health posts. Next slide. The team that we had that were going through in all these facilities, we had somebody who was coming from the ART TB specialist, was an ART TB specialist, then we had an ART TB nurse, and then we had people that are doing reproductive health, maternal, newborn, and child health. Then we had people that are working in strategic information. Then we had community supervisors as well as the counselors. These, when they went to the sites, they made sure that whatever they were offering, they were also integrating non-HIV services. And one of the non-HIV services that they integrated included cervical cancer screening, screening for non-communicable diseases, as well as making sure that they tried for HIV. However, for the purpose of this presentation, what we are showcasing, we are only showcasing cervical cancer screening integration as well as HIV prevention. This is not to say the numbers for non-communicable diseases were not as important. They were as important. However, we just picked some numbers that show relevant for this presentation. Next slide, please. And this is what our results are showing. We realized to say from 2017 to within these primary healthcare services, we had an increase in terms of services that started integrating. At first, in a district called Chirilabombwe in Zambia, this particular district only had a number of sites, like 7 sites are the ones that were offering ART and integrated services. However, these services, by the time we are coming, by 2022, they increased to 2016. By 2023, we saw to it to say there was a growth of up to 128% of the sites that started accessing these services. Further, in another district which bordered Congo, which is Chirilabombwe, there was an improvement in terms of sites that were also integrating. What did we see in the process as we integrated? We realized to say from the period in these 14 sites which we are integrating, before integration, these sites were not able to offer any HIV services. These services, they were only offering services for OPD. And these OPD services included just routine primary health care screening for first line. Any complicated cases were supposed to be referred. When we brought this model, we brought people to the facilities and decongested the health centers. And the first thing that we saw is in the period that we are talking about, 18,637 people access PrEP. Apart from that, we have had more than 8,000 people. That is 8,895 people accessing ART. And then antenatal services, we see it to say 17,940 access antenatal services. Of those, we also had women that were accessing PMTCT services. And then not only that, we had cervical cancer screening equivalent to 4,627. We had positives, and of those positive, we had more than 50% that received cryotherapy within these health posts. Of course, the other numbers that, as I said, we didn't include them, particularly for NCDs, which I think would be of interest. Once we integrate, we see to it that these services are able to be taken to the health post. Next slide. So in conclusion, what are we saying? Integrating health services at primary healthcare level actually helps make sure that people access the services that they need or the services that they would have accessed at a specialized health center, because one, it cuts the cost that is required to access this particular service. And not only that, it decongests the busier health facilities. And not only that, we know to say skilled healthcare workers are able to transfer the skills that they have to the health post. And from there, we have quality health services being accessed by our communities in underserved communities. We understand to say this can lead to provision of equitable, cost-effective health services, and we will achieve universal health coverage, and at the same time achieve the 95 global AIDS target. What are we saying at the end? Next slide. Expanding a range of healthcare services at health post level, we are saying it is possible provided we have quality healthcare workers. We have specialized healthcare workers who are transferring health services to the people that are found at the health post. And once they have transferred the skills, you make sure to say the services are being accessed and the service is taken to the community and the community will be able to access the service. Thank you very much.
Thank you very much, James. Another round of applause. Round of applause, please. We'd like to engage. We have a small technical issue before we continue. So I just want to check again if the floor manager is in the room to please join us on stage so that we can resolve this. We have another colleague here who's under a different track, but he's scheduled to speak in this room. So we just need to go ahead from the floor manager whether, okay, so the floor manager will come up in a bit. In the meantime, we will engage with James. You'll have an extra 5 minutes, James, and so we can do a Q&A. I'll ask the assistants in the room to please help with passing the mic. Thank you very much, James. Do we have questions, comments, reactions to James's presentation?
There is a question. She has a question.
Thank you so much for that presentation. I just had a follow-up question on the teams that you mentioned, and it looked like the teams were composed of maybe 5 or 6 different people. And I'm curious, was the team then permanently based at one of the posts and they traveled to others? So just a little more information about the team makeup. Thank you.
Thank you. So the team composition comprises of a clinical staff who is a clinician, who is an ART-TB specialist. Apart from that, we have nurses that are particularly nurses that are working in ART-TB, specialized in ART-TB. Then the other team we have is reproductive health, neonatal and child health nurse, again, that is a midwife. Then apart from that, we have the community people, and the community people we have a counselor supervisor. This is a professional counselor. Then we have the community team, that is lay community, lay counselors that are going in the community. So in these, they are not stationed at any of the health posts because we are using a hub and spoke model, meaning these are stationed at the hub where they now have a schedule to go around the facilities to offer technical support at the same time to make sure that they mentor the facility staff to make sure that there is transfer of the skills until when they are up to speed with offering the services. So our work involves in some sites where the team is directly offering the services. As they offer the service, they are working with Ministry of Health colleagues to make sure that over time there is sustainability of the intervention that we are doing. And we have seen that most of the sites where it has been done effectively, there is sustainability. We are observing a number of the 2 districts. Their Ministry of Health has taken up most of the services, and therefore it is completely sustainable going beyond the project that we are doing. Thank you.
Thank you. I'm wondering whether the staff in the kind of spoke, whether there was any resistance to adding this as a service, in terms of feeling already overwhelmed with the workload, or, that you're asking me to do something that I wasn't employed to do, or, and if you did encounter that, how did you deal with it?
Thank you very much. Another very brilliant question. So we did, because what we are doing is we are working with Ministry of Health. So we have a memorandum of understanding with Ministry of Health from the word go, meaning we are supporting Ministry of Health to make sure these services are taken closer to the people where they are. Therefore, these colleagues that we are finding within the spokes, these are people that are employed by Ministry of Health, and they are paid to offer the services within the community. The only thing was they are lacking these skills. They are not able to offer because of the technicalities of not being able to offer this service. And therefore, transfer of this knowledge as well as the skills made it possible for them to be able to do it even in absence of the team. And therefore, there was no much resistance because from the word go, we engaged the Ministry of Health to make sure that they are aware of the process. And not only that, we worked with them. When we go to the facility, first and foremost, we engage a district at district level, and then the district engages these people to say, we want to expand the services. And Ministry of Health, I think it has taken up the measure because it has worked very well and it is improving integration in Zambia. Thank you. There is another question here.
Thank you very much, Mr. J. Mwanza. I think your topic is very, very interesting. You want to you expand the quality integrated services health poster, which promote the universal health coverage. So your activity mainly deal with the non-HIV services. So how do you integrate in the laboratory activity with the your services? Because mostly vertical activities rely on tests. So how do you comply with that?
Thank you very much. Another very great question. So the composition of the team at the hub, it also involves these, the team that I mentioned on the presentation are only the team members that are going to the spokes to offer technical support. However, at the hub, we have what we call a hub lab, and the hub lab is the one that is able to process all the samples that are going to be coming from the health post to be processed at a hub lab, and then the results are transmitted just as such. So we have lab staff, as well as we have people from pharmacy that deal with supply chain commodities. So we have a bigger team that are supporting the process. So we have a comprehensive team that makes sure that the service delivery is valuable. Thank you.
So if there's any last takers, okay. Thank you very much, colleagues, for that engagement. Thank you, James. We have sorted this small logistical issue, and we've got the go-ahead. Good news from the floor manager that we will go ahead with the next presentation, even though it's under a different track. But integration, we have to all agree, is cross-cutting. So we will hear from our colleague, Mr. Anthony Kinywa, who's come all the way from Kenya. The booth, if you could kindly load Anthony's presentation. He's going to share on assessing population level outcomes for HIV programs among female sex workers and men who have sex with men. And this is a program that's implemented in Kenya. Take this opportunity to welcome you, Anthony, to share with the colleagues.
Thank you so much. Good afternoon. Thank you. Sorry for the slight technical issue. So I'll be presenting the work that we did in April this year as a program where we were assessing the population level outcomes of HIV program among female sex workers and men who have sex with men. Next slide. So according to the estimated key population size estimate, which was done in 2020, which was a national activity, we are estimating that we have close to 200,000 sex workers in the Republic, and 60,000, more than 60,000 men who have sex with men, and also people who inject drugs, close to 30,000, and close to 5,000 transgender people in Kenya. So we did an internal hotspot validation where we wanted to understand the dynamics of the hotspots after COVID. And we found that in Nairobi, we have close to 40,000 female sex workers and close to 10,000 men who have sex with men. And transgenders are close to 2,000. So that is information from the validation that we did last year in September 2022. And Nairobi, why we focus on Nairobi is that Nairobi contributes to 20% of the key populations in the Republic. That is why we were interested to learn from Nairobi, because it was going to be a representation of the whole Republic. So why did we want to do the study? The reason why we wanted to do the study is that we don't have much information that is focused on program outcomes from most of the surveys, and we wanted to do that in Nairobi and have a picture of how the Republic would look like. Still, we don't have a cost-friendly approach that is rapid and can be done over a short period of time, and also easy to be done by anybody. Next slide. So the objectives of the study was, we wanted to estimate the incidence levels among incidence and prevalence levels among female sex workers and men who have sex with men in Nairobi. Also, we also wanted to understand whether the key populations are able to access biomedical, behavioral, and structural interventions in Nairobi. The other objective was, we also wanted to learn we also wanted to understand how access to HIV prevention package and treatment services among the key population and the barriers that are there, and how to mitigate the barriers or the gaps. Next slide. So on the methodology, we did a mixed method cross-sectional study. That is why we are calling it an enhanced polling booth survey, because we added some components on top of the polling booth survey, where we had a biobehavioral survey and also did focus group discussions. So the flowchart that you see on your right illustrates the process of how we did the polling booth survey. We started off by doing a sample frames different for the two populations, where we sampled different hotspots for the female sex workers and also for the MSMs, and randomly selected the ones that we're going to work in. Also, we randomly selected the days that we are going to work in those sites, on those hotspots, and the teams that were going to do the work. We had 4 teams that was working in Nairobi, and Nairobi has 17 sub-counties, and we wanted to have a picture of all the sub-counties. So the 4 teams comprised of community researchers who are female sex workers, men who have sex with men, and we also had prevention officers who are more of field officers who are moderating the sessions, the PBS, polling booth survey. We also had a HIV testing service provider who was doing more of a HIV rapid test, and we also had a clinician who was also certified to do HIV tests. So after we did the selection of the sites randomly, we went to the sites during the peak days and also the peak hours, and engaged the female sex workers and the MSNs, working closely with the community researchers, where we identified potential respondents or participants in the study who went through a screening process, which was done by the community members or the community researchers. After the screening was done, they progressed to the PBS, to the session or into the hotspot, where they interacted with the prevention officers who took them through consenting, where they were consenting for the polling booth survey. They were also consenting for the rapid HIV tests. They were also consenting for drawing blood for either viral load tests and recency, and also consenting for a rapid TDF urine test. So after consenting, we did enrollment. We had a tablet that we were enrolling the participants and also issuing them with a unique number, and also issued them with slips that had those unique numbers for that session. So from there, we proceeded on to do the polling booth survey, which I'll explain in another slide that is ahead. After doing the polling booth survey, we did tally and also engaged the community researchers in tallying the responses of the participants. And after doing the tallying, we gave out the results to the participants. And after doing the results, we engaged them. We did a group counseling, pre-test counseling in the group, because all the participants had to go through HIV testing. After doing the group pre-test counseling, they proceeded on to get the urine. We did urine for everyone so that we don't disclose the status of the participants. And with the unique number that we issued them during the enrollment, they handed the urine to the clinician who did an individual interview with all the participants. So in the interview, we also used a tablet that was communicating. The information that was there in the prevention officer during the enrollment stage was relayed to the clinician. So the clinician knew the people that he was going to interview. So after the interview, if someone indicated that they were on PrEP, that is when the clinician who was alone in the room would do the rapid TDF urine tests to check PrEP content. Right? Then after that, that's when we went to. That's when after the individual interview, the participant would go and get tested for HIV. After the test, depending on the results of the test, if someone tested negative, you would be linked to a champion, a PrEP champion, who would counsel them on PrEP. For those who tested positive, then the clinician will come on and draw blood for recency tests and also for viral load, which was done in our labs. So the only tests which were done on site was the urine test that was testing for PrEP and for HIV test. Next slide. No methodology. Go back. Go back. Yes. So this is if you look at the picture, that is an illustration of how the session was done. So that picture was taken before we did the polling booth. We had to visit the site, engage the owner of that hotspot, and do that preparation. So in that picture, you'll see that we have 3 boxes, a green box, a red box, and a white box. A green box will imply that someone is saying yes to that response. We had a set of questions, and each participant will have a pack of numbers, maybe number 1 to 30 something, depending on the number of questions that we had for the session. So we had different sessions, different questions for MSMs and FSWs. So what they will do, the moderator will engage the participants to drop their responses in the right boxes, either on the yes, which is a green box, or on the red box, which was responding to a no, or white box, which was responding to a non-applicable question. So after doing the polls, that's when we did the tallying, as I had highlighted. So my colleague has a poster that has an in-depth information on the methodology. Maybe you can visit the desk. Next slide, the results. So we were able to conduct 64 PBSs focusing on the female sex workers, where we were able to reach 759 female sex workers, and also were able to cover 35 MSM sites, where we reached 398 MSMs, and we were able to conduct 20 FGDs, with 13 of them being targeting FSWs and 7 targeting MSM, based on our sample size. The table on your right illustrates the distribution of the sites and how we randomly selected and conducted the PBSs. Next slide. So on the results, condom use. So condom use, these are the results from the polling booth survey. That is the tally that we did across all those sites that we visited. We noticed that the first graph illustrates that close to 81% of female sex workers reported that they had used a condom in their last sex act, either with their client or with their regular client, and 73% of MSMs reported to have used a condom with their last sexual partner. And then when it comes to consistency on condom use, in the last 3 months, 52% of female sex workers reported to have used a condom consistently with their clients in the last 3 months, compared to 44% of MSMs who had used a condom with their partners in the last 3 months. The last graph illustrates the availability of condoms in Nairobi, where 40% of female sex workers reported to have not had a condom in the last month, and 50% of MSM reported that they had not, there was inavailability of condoms in the last 1 month. Next slide. PrEP use. So in terms of PrEP use, 28% of female sex workers reported to have used a PrEP in the last 12 months, compared to 21% of MSMs who interacted with in the exercise reported to have used to be using PrEP in the last 12 months. So that information, we got it from the PBS responses, where they were asked a question whether they have been on PrEP for the last 12 months. Then the second graph illustrates the responses or the results that we found from the urine test, where we found out that 16% of female sex workers were actively on PrEP, as compared to 13% of MSMs who are currently active on PrEP, based on the results of the rapid urine test. Next slide. So we also had a question on where we wanted to assess police violence, stigma, and discrimination, where where 26% of female sex workers reported to have experienced police violence in the last year, in the last 12 months, and 11% of MSMs reported to have experienced a police violence of any kind in the last 12 months. On matters stigma, female sex workers, 12% of female sex workers reported to have experienced stigma and discrimination while receiving services from a healthcare provider. And 13% of MSMs reported to have experienced stigma and discrimination while receiving services from a healthcare provider. On the last graph, we wanted to understand the situation on violence in terms of response. 53% of female sex workers reported that they had received some of any kind once they experienced violence in the last 3 months. And 59% of MSMs reported that they had received a support of some kind after experiencing GPV. Next slide. So on mental health, we also had a question on mental health where we wanted to understand experiences of the two populations, where 73% of female sex workers reported that they had experienced a loneliness, sadness, a duration of 2 weeks in the last 3 months. And 53% of MSNs also reported that they had experienced loneliness and sadness for a continuous period of 2 weeks in the last 3 months, indicating that mental health was a big issue with the population. So on peer education and clinic visit, I wanted to assess the outcomes in terms of our peer education and whether we have some positive outcome. 69% of female sex workers reported to have met a peer educator in the last 3 months. So this study was done in Nairobi, and we have different partners working in Nairobi with different peer educators. So this implies that we are assessing the impact of our peer educators in Nairobi for all the partners. So 69% of female sex workers reported that they had met a peer educator in the last 3 months, and 66% of females of MSMs, had reported that they had met a peer educator at one time or at one point in the last 3 months. Then we also wanted to know that in terms of referral, once they've met the peer educators, what kind of impact is there? So 68% of female sex workers reported that they had visited a clinic in the last 3 months, and 62% indicated that they had visited, indicated that they had visited a clinic or a DICE in the last 3 months in Nairobi. Okay. Next. So in terms of HIV prevalence, 14% of female sex workers who were tested for HIV. So 14% of female sex workers of the ones that we tested for HIV, 14% of them were positive, and then 19% of MSMs, of the people that we tested for HIV, were positive. And then in terms of ART uptake, 87% of female sex workers reported to be actively taking their ART, as compared to 94% of MSMs who are currently on ART. On viral suppression, 86% of female sex workers were virally suppressed, and 80% of MSMs were virally suppressed. Next slide. So on HIV recency, 12% of the newly infected FSWs, we found that 12% of them were recently infected, and 20% of MSMs were recently infected with HIV. In terms of long-term HIV infection, the ones, the KPs who are in ART or had been infected for a longer period, we had 88% of women sex workers, and we also had 80% of MSM. So on next slide, conclusions. So the enhanced polling booth survey, we have seen that it is a rapid method or approach that can be used by different programs, and it is easy to be implemented, and it's an important method to assess the outcomes of our interventions and where we're working. Another recommendation or something that we learned from the study is that the study highlighted the gaps in terms of availability of some commodities and also utilization of HIV prevention commodities or services, especially PrEP and condoms. So we also learned that we have a huge gap in terms of linkage and also viral suppression. We haven't attained the 95 based on the data that just presented. And also the study highlighted that in terms of incidence, I was not able to share a slide on this, but in terms of incidence, for the female sex workers, we had an incident rate of 1.9 as compared to the MSM, which was at 3.4, which was double the figure. So we noted that the incidence rate in terms of HIV is higher amongst the MSMs as compared to the female sex worker. And as highlighted, mental health, high experience of police violence, stigma, and discrimination are some of the barriers that hinder people from accessing HIV prevention and treatment services. And also, we have seen the impact that peer education has in terms of accessing services, as highlighted in the study. And also, we are seeing that the enhanced polling booth survey indicates that it's a critical area that the government and other implementing partners need to invest in or focus in terms of helping programs understand the impact or the outcomes of their interventions. Next slide. I would like to appreciate or acknowledge study participants, the study teams, Bill and Melinda Gates Foundation and PEPFAR, the Nairobi County, and also the Ministry of Health. Asanteni sana. Thank you so much.
Thank you, Anthony, for sharing and for being proactive to make sure that your session, your presentation does not fall in between the cracks. Sharing insights from the study conducted in Nairobi, Kenya. We are out of time and we do need to wrap up. I want to see if there's maybe one quick burning contribution question. We can take that and then I'll wrap up in 2 minutes. For Anthony, any engagement? Okay, whilst colleagues are still gathering their thoughts, I wanted to make a reflection. Thank you very much, James, for sharing those insights. And this is really adding on to the body of evidence around the effectiveness of providing the services in an integrated approach to maximize the opportunities that the communities have with the health sector to provide more and to ensure that we minimize those transactional costs on having to return. And I think you have really demonstrated to us how the results from this feasibility study have shown the results in terms of increasing numbers for HIV prevention as well as treatment. There was clearly some indications from the data perspective in terms of the increase in numbers of those that were put on PrEP, started on PrEP, and those that were started on ART. I think the key words also taken from James's presentation is this transfer of skills, ensuring that even as a pilot or as a project that is testing the visibility, that we can ensure that there is a plan in place to transfer skills to the Ministry of Health and to ensure that there's sustainability. There was a clear indication that retention for those that were on treatment increased, and that the opportunity provided for increases in treatment for screening for cervical cancer and other services. And I think from Anthony, we learned a lot in terms of the clear gaps that continue to remain for the populations most left behind. Even though this is only done in Nairobi, I think these lessons all of us can take back in terms of the areas that we need to continue to invest more in, areas around prevention and access to treatment for key populations, and in this case specifically for female sex workers and the male men who have sex with men. And that this information findings and the recommendations will continue to feed into the policy and evidence-based learning at national level, and continue to also share with us in platforms like this to ensure that we can accelerate action in this area. 2030 is around the corner. The populations most left behind, if we continue in this trajectory, we will struggle to meet those targets. With that, I want to thank you all for your attention. This is a lunchtime session. You all made the time, and it's the last day of the conference. So thank you very much for turning up and for your engagement. This is the end of the session. Thank you. I just thank my interpreter and thank also the floor manager for all the arrangements and the colleagues in the booth for all your support. Thanks.